Hello and welcome. My name is Donna Cryer. I am founder and CEO of the Global Liver Institute, the largest liver patient advocacy organization in the world, and the convener of the Pediatric and Rare Liver Diseases Council. I hope you all have been enjoying all of the content and conversations that we have. I want to use another C and say catalyze, but I love alliteration a little too much, but that we have, and then conducted comes along, that we have put forward and in front of you throughout this month to shine a spotlight on the fact that liver diseases can affect anyone, including pregnant women and infants, children. Truly, liver diseases affect families and communities of all shapes and sizes, hues, and geographies. And so, because GLI and the council are not just convening organizations, but we are agenda setting organizations, I have brought together with me two really forceful leaders in this space, as we want to make sure that we've pulled out the issues, the gaps, the needs that patients, parents, families need. And we are advancing an important agenda of solutions for them. And so to help me with that, I have Jennifer Lau of Bear and Donna Buenavides of the ICP Care. Welcome, ladies.
Thank you.
Thank you.
I seldom get to meet another Donna, and so I am very excited about that. It must portend very special things. So why don't I start with you? Why don't you tell us about what ICP stands for, first of all, and the work that your organization does?
So ICP stands for intrahepatic cholestasis of pregnancy. Is quite a mouthful. And it is a high-risk pregnancy condition that affected me in all of my pregnancies. It does skip pregnancies sometimes, but our organization is we're the largest advocacy group, patient advocacy group. We are a 501c3 nonprofit. So the work we do is so important to be able to help anyone affected with ICP, and we bring together a support community. We attend conferences, we share educational information. So there's so much work that we do in order to help not only patients, but also healthcare professionals. There's a lot that with this condition may be myths or just misconceptions that could be kind of confusing. And again, it makes it challenging for patients and even doctors, even healthcare professionals, and how it presents, the condition among, different women and different people in general. So
thank you. Jennifer, tell us about your organization and your work.
My name is Jennifer Lau. I started BEAR, which stands for Biliary Atresia Research and Education. We actually, we're going to be celebrating our 1-year anniversary come February. So we're really excited. We are also a 501c3 nonprofit. And our biggest drive was that there really wasn't an organization out there for patients and families in biliary atresia. So we decided to form the organization, and like ICP and many other liver disease organizations, we, first and foremost are there for our patients and families with educational resources. We also work with physicians along the side to advocate. One of the biggest things in biliary atresia right now is to advocate for just quicker detection within that liver disease. And so we've gone from like 0 to 1,000 within this short time frame. We've had a lot of projects, a lot of initiatives that have really stepped off the ground pretty quickly. But one of the greatest things is that just everybody within the liver disease and transplant community, because biliary atresia is number one reason why our kids transplant, have really embraced us with open arms. So um, we we're definitely one of those organizations that are really there to help among the patients and families, to help advocate not only for their kids but also for the families as a whole. So we're coming up on the first year, and just really excited to be a part of this community.
That is so exciting. And I'm just, congratulations.
Thank you.
I know what it means to meet that
Mhm.
1 year mark, even just to just make the decision that you're going to vote your time and talents and treasure to a cause and be committed more than you already are by your experience and the help that you were giving to other people, but to, file the paperwork and to wait for the designation and to be able to do this with a seriousness and rigor. I really commend you. It's something I almost feel like to avoid it at all costs. If you can't, having advised many nonprofits and now led GLI for some time, it is not for the faint of heart.
Right.
But it's certainly easier than having a transplant or parenting, a child with a rare disease. So if you've done that, then you can, nonprofits is not so hard.
Right.
But congratulations
Thank
nonetheless.
you.
On the issue of earlier detection, I think that we've talked to our counterparts in the British Liver Trust and the Yellow Bus campaign, and just really working to make sure that there is better inclusion of our diseases in newborn screening, better attention in from OBGYNs to this, and pediatrics and family physicians. So maybe we'll go sort of almost specialty by specialty. What do OBGYNs and those who are counseling pregnant people, couples, partners, families, what do they need to be telling people about the risk for liver disease for themselves and their children? I'll start with Donna, and then we'll go to pediatrics and beyond.
Well, for cholestasis or pregnancy, it is genetic, but it's multifactorial. It is more prevalent in twin pregnancies, triplets, multiple pregnancies, IVF as well, because it has a hormonal component to it factor. But that having that genetic, in our DNA, it can skip generations and such. And I personally have two sons, but I have spoken already to my boys, to let them, and they are very involved in ICP care since they were little. So they're very much aware that it very well may not affect them being male, but they can very well pass it on, the gene, to their children, and it can continue. So as far as having that knowledge and that information, and that, because I believe that so much is lost sometimes in the medical, in your medical health, and your from generation to generation. Even from me, my father had liver issues, and so where it stems from for me is definitely from my paternal side, and my grandmother had ICP, even though I don't have it confirmed, but it stems from that side. So just having that knowledge and that information, and having OBs, just being able to advise them of that it just doesn't end at your pregnancy. Because a lot of times we find in our community as well that, you're thinking, okay, well, I had my baby, it's over. no, it's not over. You need to kind of think of it as, long term, in the
Mhm.
future, in in the generations to come.
Mhm.
So that's something I think that, we're also trying to really bring that component, that awareness to
Mhm.
our community a little bit more, with just having, either blogs or information on our website, community conversations, to be
Mhm.
able to kind of bring that in, to highlight it a little bit more. And that's important for sure.
Well, you've just added another group to our, I won't say target, I'll say invitation list, fertility specialists, because I don't think
Yes.
that most people going through, fertility procedures have any type of liver risk information or ICP information as part of that. And we have great friends over at Resolve, and we should absolutely make sure that the fertility specialists and organizations like Resolve are added to our invitation list when we're having these conversations. So, in addition to
Absolutely.
OBGYN, um, going back further and further. So that's fantastic, and I think that taking family histories and understanding your liver medical history of your family is something that we can highlight. We know that people ignore their current liver information,
Yes.
and so putting the historical liver information back into the family history, or into the family histories for the first time, to inform care, is something else that I think you're absolutely right to call out. So, Jennifer, as we're working our way through the specialists, what should pediatricians be thinking about, or how can we, reshape or redo their medical education and continuing education, to help them not miss, um, these patients.
Right. So I think, especially, with biliary atresia, one of the things that we advocate for is, that early detection, and that begins at birth. That begins at that blood panel, the bilirubin panel.
Mhm.
And so many of us have come home with our child who have been jaundiced, and have been told, with newborn jaundice, it's normal, it's okay, it's breastfeeding jaundice, it's normal, it's okay. And one of the things is, it's if it's a simple newborn screen, to be able to just try and help detect biliary atresia, why not?
Mhm.
And so, eh, that is one of the things that the biliary atresia community has been trying to push and trying to help as well. Um, and then, so that actually can start in the hospital, inpatient. That starts with the nurses, the doctors right there inpatient. And then once you leave the hospital, it then starts with the pediatricians. And it starts with maybe listening to the moms who come into the appointment saying, I think there's something wrong with my child. Um, you know, it, my personal experience was that I kept feeling something was wrong, and I was lucky enough to have a good enough pediatrician to listen to my voice. It just, we kind of waited a little bit too long. There are other families that weren't as lucky, and so it wasn't caught soon enough.
Mhm.
So I think it's really having those conversations and educating the
Mhm.
pediatricians, to understand that early detection with biliary atresia and any liver disease, quite frankly, it is going to give better outcomes for these children moving forward. And so that is something from an educational standpoint that a lot of, like my organization and other organizations that are out there continue to have those conversations, not only within the community, but also with the physicians that are out there to kind of bring that more to the forefront as we move forward to bring awareness for liver disease.
Are there tools? Are there better alerts in the EHR? Or how can the systems support physicians to make it easier for them to do that? Is a question that I always wonder, in fairness to how many issues they have to deal with and how many things they're seeing, and how can we make them see zebras instead of horses appropriately when they need to. Thoughts on ways that we can make it easier for them to do things.
I know, in speaking with one of the hepatologists, really a good friend of mine, was an idea of making the algorithms better for the pediatricians, making that checklist a little bit tighter for them. To be able to, with the help of with the detection of the liver diseases. Another way, which I do know in liver disease, and I do see it a lot in transplantation, is this community is so open to physicians and patients coming together and working together to making the space better. And so I think the more we collaborate together, the more, advocacy organizations, the more like with GLI and other organizations are out there, the more and more we collaborate and have these conversations, I think the more we're going to see the needle move. And I don't think there's a magic wand, right? I don't think it's X, Y, and Z. This is what we can do. But I do feel like we're moving the needle forward a little bit better, and having those conversations and being transparent about those conversations. And I think they're starting to they're listening better to us as far as what does this patient and family community actually need? What are we missing? What's going on out there that we're missing? And so I'm hopeful. I'm hopeful that if we continue to kind of have these conversations and organizations like ours, like GLI, BEAR, ICP, the more that we're invited to the table to speak with them, I think in the future, the better off that possibly we can be within the liver disease space.
I absolutely agree that the more liver advocates, the better. It's amazing the places now that will use a liver example where they may not have before, just because we've started to have it in their thinking. And so if there's something that's going to be changed or innovated, we want them to have liver on the brain, if you will, and be thinking about us. Donna, let's continue this conversation about which needles need to be moved. So we've talked about, better liver in the family history, better inclusion in fertility information. It seems like better newborn screening inclusion. I want to make sure when we end this, we have the needles that we want to move, so that when we ask and hold people accountable, they know what we're trying to hold them accountable for. So what needle would you like to move? What change would you like to be able to measure when we are here at next year's Pediatric and Rare Liver Disease Month? On your microphone, you're muted.
Thank you
Okay.
for reminding me. I did it on purpose because it
Yes.
was a little bit of noise and I didn't want to interrupt Jen's speaking. Okay, so for us, for our community and for anyone affected, there are some sore spots, and one of them being just the amount of time that it takes for the uh, the blood result to come back for our bile acids. And the bile acid blood test is important because that is what is used to diagnose cholestasis of
Mhm.
pregnancy. Now,
Mhm.
the liver function, the hepatic panel can be done. It can be, really quick turnaround time, but that's
Mhm.
not necessarily used to diagnose it. It can be with
Right.
symptoms and such. So definitely improving on just the amount of time it takes for the results to come back. And right now, the major labs, it takes anywhere from 2 days to 6, even sometimes 7 days to return back. And because time is of the essence for
Mhm.
cholestasis of pregnancy, and then many times, you know, um, women are itchy, let's say at 37 weeks, at like
Right.
predominantly, or at the tail end when the risk is higher. And then
Mhm.
so there's really a shorter time span of being able to react,
Mhm.
with the correct, let's say, diagnosable levels
Mhm.
at bile acids, for example. Now, so that's definitely something that we actually have tried to work on our
Mhm.
own to try to make change. And, it just sometimes take a little bit more powers that be to make things happen. But so definitely improving the turnaround time, and
Mhm.
to a day or less. I mean, it can happen.
Right.
It's being done in other countries, so why can't
Mhm.
we? And yeah, and it's doable. So definitely that's one big
Okay.
major area of
I love
change
working
that we
on
need.
that. I come, the arc of my career, I've already seen us move from why do patients even need their own data? What would they do with it? To I guess we could put it, in the portal, but it's going to have to wait 7 days or more and be reviewed by, to now getting them immediately, released. So I've seen that progress on the part of patient advocates, on health information technology advocates,
Mhm.
and working in partnership with labs. So I think if scientifically doable, it should be, workflow doable. And I love that as an issue, because I think
Yeah.
having that information timely, in conjunction with the visit, often, you go about your life after a doctor's visit, and, when as lab worker results just sort of peter or pop in over, time, you're less likely to pay attention to it and take action on it. So I think having it close in time to the visit um, is a realistic ask.
Yeah, definitely. Especially because we're dealing with, the worst case scenario risk for cholestasis pregnancy patients are, your baby can die, you're in
Right.
utero. So, and unfortunately, that's something that I experienced, and you know, it's serious. So timing is necessary.
I thank you for sharing that, and I think that one of the reasons why it was so important for us to highlight parents and pregnancy uh, in this month was because people don't realize that children die. Um, People don't realize that liver disease, even in utero, can be so serious. Um, Many people think that it's liver diseases are only something that accumulates with decades of misbehavior and misuse. When for so many people that is just not the case.
Mhm.
They haven't done anything at all. They haven't even been born yet. And the liver disease is affecting them and their mother. And so I really thank you for sharing. I think, there will be someone's life that will be saved because they know, because they heard this. So thank you. Jennifer, as you've navigated biliary atresia, and mentoring, creating a whole organization to mentor families and to advance research. What are some of the gaps that you're seeing, or what are some of the um, best practices from other countries that we might sort of, borrow or help scale? We know about, the stool cards from Taiwan and some other Asian countries, other things, or places where we can be learning lessons and making sure that, the access is better equalized to this knowledge.
So I think that that is the gap. I think that we need to make this more global.
Mhm.
I think that there are other countries that are doing amazing things within the biliary atresia space that I think it's time that we build that bridge over the pond and tell them to come on over, or we go over there. And I think that it's time to make this a global collaboration of figuring this out. Biliary atresia is one of those liver diseases where we have no idea how this happens still. And, we have two treatments right now, and that's the Kasai procedure and liver
Mhm.
transplant. And a lot of us, I mean, I'm sure, surgeons probably wouldn't like to hear this, but, a lot of us parents that advocate, it's our goal to put transplant out of business one day. I mean, we don't want to transplant,
Right.
because it brings on a whole slew of other,
Mhm.
you're training one disease for another,
Right.
basically. And so, the biggest gap, I think, is instead of having, centers working all in their little silos, I think it's time we make one big silo and we all work together, we all collaborate, and we figure out why biliary atresia happens.
Mhm.
Because until you have the why, we're not going to get any more treatments.
Mhm.
And that's my opinion. I could be totally off fet. I'm not a physician, so I could be totally wrong in that. But from my experience, I just I mean, in order to treat something, I feel like you need to know the why. And I've always been that parent, and I know I'm sure I've been that squeaky wheel that I've annoyed many, many doctors, but I've been that squeaky wheel. I've always asked and pushed, but why?
Mhm.
But why? And I feel like that work isn't done yet, and I think that that is the biggest thing that we need to work together on is really making this a global effort
Mhm.
moving forward. Because, we can have all of our studies out there and we can have our theories on how this disease happens. And we can think about some therapeutics that are out there right now that could possibly
Mhm.
help curtail with getting the Kasai,
Mhm.
and possibly maybe holding off onto transplant,
Mhm.
but we still need the why, and parents still want that why.
Mhm.
And so that's where we're at, as far as from a parent perspective in the community.
Mhm. I made that case the other day. I was on a panel in Park City, Utah, and a physician of great renown was making the case that a drug that resolved a particular or had a particular effect for a type of liver disease, was sufficient. And I said exactly what you said. People will still want to know why.
Right.
People will still want to know, well, what caused this in the first place, and can it come back, and
Mhm.
all these different things. And so while stopping progression of disease or having transplant-free survival are important endpoints, having symptom resolution are important things to do. But understanding the why this happened to avert more is something important. And I would say, hold on to that as patients and as parents, as people, participant researchers and members of this community. It's okay to ask why. I think that's how progress is made. And I wouldn't allow people to call anything sufficient. If it doesn't, then go the whole mile and answer the why.
Yeah.
So I stand with you.
Yeah, and I mean, and don't get me wrong, we've made great strides, right, in liver disease and transplantation, but I just, we're not done yet, right? And so that whole why piece is,
Right.
Yeah, it's very important.
Donna, what additional questions would you have, or as I think about creating healthy pregnancies and healthy pregnancies for the future? It's amazing how our agenda has broadened, particularly during the pandemic, to include school nutrition and environmental policy. Certainly, Jen, to your points, global clinical trial registries and diversity of those registries within rare diseases. What other things should we be thinking about, Donna, as we create a next generation with fantastic liver health?
Well, I think you guys are doing an amazing job. There's so much, obviously there's so much that ideas and for the future. But starting with just what you're doing with the panels that you're doing now, bringing organizations together and then communicating to be able to partner together to bring, just not only awareness, but also action and how we can, partner together, work together. And just from us talking, it's just so amazing about speaking about, in vitro fertilization. And then you're like, the little light bulb went up on your head, right? And you're like, okay, well, we need to get rare into, so we can have information. So, and it's necessary. So we're really, like you were saying, Jen, the bridge to the pond. So we're really, making bridges for us to connect, not only within organizations, patients, and again, social media, although, I always say social media is a beast, because it is. It's really beneficial. And I use it in that regards, anytime I use it in a personal level. And of course, for ICP Care, it's just such an amazing platform to be able to spread not only awareness, but also to work together within organizations to be able to spread awareness and then make change. And again, it all connects us, and that's what we need to do, right?
Right. I think we're all committed to be where people are, where to go, where they're seeking information.
Exactly.
Particularly when we realize the conditions that we're discussing are by definition hitting women of childbearing age, and we actually see a huge rise in chronic liver disease of all types in people 25 to 54, key prime of life, and increased mortality, increased deaths. And so this is something that's serious, that's urgent, that deserves a spot on the public health agenda. It deserves a spot in the conversations for every family, deserves a spot on everybody's, Instagram feed and Facebook page. And so I'm just so honored to be able to partner with both of you and all of your volunteers and advocates to work on this together. So thank you so much for sharing this time with me today. And thank you for the work I know we're going to do together in the future.
Thank you so much for having me and Jen, and just for bringing us all together to share.
Absolutely. We'll share everyone's social media and websites in the show notes to this roundtable episode, so that everybody can find you.
Thank you.
Thank you.